In the modern scientific and pharmacological communities, there is a great deal of peer reviewing as well as a multi-stage drug approval process to ensure the validity and safety of any given treatment. However, throughout medical history, such rigorous guidelines have not existed, resulting in numerous therapies whose efficacies are up for debate. This lack of vigilance resulted in treatments that were debatably worse than the disease. The 2008 documentary, The Lobotomist, details the conception and development of the renowned brain surgery known as the lobotomy. The documentary covers the work of how Dr. Walter Freeman crudely popularized the lobotomy after Dr. Ygaz Moniz first created the ideology in 1936. The lobotomy was soon phased out in the late 1950s before the introduction of the first antipsychotic drug, chlorpromazine. With the newfound technology of antipsychotic drugs, the lobotomy became a nightmare of the past, and the future of mental illness intervention was hopeful.
In 1936, Dr. Ygaz Moniz published his results of a novel brain surgery procedure performed on 20 patients aimed at treating severe cases of mental illness, such as obsessive-compulsive disorders and schizophrenia. His surgery was based on the idea that patients had persistent thought patterns that dominate normal psychological processes, and that these dominant patterns existed within the prefrontal lobe with connections to the thalamus. The procedure, termed the prefrontal leucotomy, aimed to sever these connections by removing 6 small cores of white matter from the frontal lobe of the brain. Moniz's findings showed 35% of patients showed complete relief of symptoms, 35% showed some improvements, and 30% showed no improvements. Freeman took particular interest in Ygaz's findings, and while he had a PhD in neuropathology, he lacked a medical license and so worked alongside neurosurgeon Dr. James Watts to develop Moniz's procedure and rebrand it as the lobotomy. Freeman and Watts performed their first lobotomy only months after Moniz's publishing, making several excisions in the frontal lobe. After 6 days, the patient experienced transient language difficulties, disorientation, and agitation, but was able to leave the hospital, and so side effects were overlooked and a treatment was considered a success. Although the lobotomy's moral and scientific grounds were disputed among the scientific community, Freeman engaged in several interviews promoting the procedure, gaining massive media coverage and support from the public, being portrayed as one of the greatest surgical innovations of this generation. Between 1936 and 1942, Freeman and Watts performed 200 lobotomies and reported 63% of patients showed improvements, 23% of patients were unchanged with regards to their diagnosed symptoms, and 14% of patients suffered severe side effects and even death. Freeman was born into a family with a prominent medical legacy, and so the ambitious doctor needed to create a name for himself and was unhappy with the surgical equipment and expertise required to perform the lobotomy. Upon further development, Freeman invented the transorbital lobotomy, where he would use an orbital clasp and a mallet to break through the orbital roof, where he would sweep the orbital clasp in multiple directions, essentially obliterating parts of the frontal lobe. Freeman first performed this procedure in his office without the supervision of Watts and was reprimanded for performing such a medical procedure without a license, leading to the end of Freeman and Watts' partnership. Freeman invented this procedure so that the transorbital lobotomies could be performed by anyone, as the method was easy and only required anesthetization by several electric convulsions. Mad with ambition, Freeman traveled the country, spreading the word of his newfound surgery of the soul, as termed by the media, that could be performed by even a nurse. Over the following years, thousands of transorbital lobotomies were performed, and eventually the inconsistent outcomes of the procedure were recognized by the public, and they began to turn on Freeman. Some of the side effects include severe intellectual impairment, personality changes, dementia, epilepsy, and even death for roughly 2% of the patients.
After the introduction of chlorpromazine in 1952, and other antipsychotics following this, the amount of resident patients in psychiatric hospitals decreased dramatically from about 600 to 100 in 100,000 adults from 1952 to the year 2000. This statistical data is from the USA. Despite this, chlorpromazine is not used very frequently now, although the efficacy of many antipsychotic drugs use chlorpromazine as a type of standardization. Compared to more modern antipsychotic drugs, chlorpromazine's side effects outweigh its positive impacts on a patient's life. Some of these side effects include heavy sedation, moderate extrapyramidal symptoms, moderate muscarinic symptoms, and moderate galactorrhea. There are also some cases of chlorpromazine causing neuroleptic malignant syndrome, which is a type of malignant hypothermia caused by the drug's effect on the dopamine receptors. Despite this, many modern antipsychotics also have similar negative side effects. However, unlike the older generation typical antipsychotics like chlorpromazine, the second generation atypical antipsychotics lower extrapyramidal side effects and have high efficacy against negative symptoms. This is due to having high potencies at other receptors beside the dopamine D2 receptor, as well as having a higher dissociation rate from the D2 receptor. Examples of some other receptors atypical antipsychotics act upon are the 2A and 2C serotoninergic receptors, or the muscarinic receptors. Even with these more modern and atypical antipsychotics, there can be many negative side effects like the typical antipsychotics, although often to less of an extent. Antipsychotics usually focus on inhibiting dopamine receptors in the associative branch of the nigrostriatal pathway of the brain. The side effects of these drugs usually come from crosstalking between different parts of the brain, which is believed to cause cognitive impairment, or the same receptor that is being targeted and usually inhibited is also involved in other functions. Examples of this are the motor branch of the nigrostriatal pathway, or the serotoninergic receptors that are involved in insulin production or cellular ATP production, especially in the beta cells. This means that the AKT pathway of the insulin receptor is inhibited and can lead to effects such as obesity or type 2 diabetes. This was seen in clozapine, which was introduced in 1972. Agranulocytosis, which is the death of white blood cells, occurs in 1 to 2% of patients that take this drug. This suppresses the immune system, making a patient more susceptible to infection, which can be treated by antibiotics, but in 4 to 6% of cases resulted in death. In addition to this, there are cases where clozapine has caused heart failure, although this is rare. However, tachycardia and hypertension are quite common, where this is seen in 25% of patients. Therefore, the use of clozapine was withdrawn in 1975. Despite this, it was, and still is, one of the most effective antipsychotics against schizophrenia, so it was reintroduced by the NHS along with mandatory monitoring. Clozapine can only be administered in a hospital, and doses are given in amounts that only last until the next visit. Doses start at 12.5 milligrams, gradually increasing to 300 milligrams over a year. Monitoring begins every third day up to week 1, weekly up to week 18, bi-weekly up to week 34, and then every 4 weeks thereafter. 30% of schizophrenia patients experience resistance to treatment, but 60% of these patients with treatment-resistant schizophrenia saw benefits from clozapine treatment. This is why this therapeutic solution is widely acknowledged as the most effective antipsychotic treatment for treatment-resistant schizophrenia, despite it having the worst side effects and interacts with the largest number of receptors in the brain.
We chose the Lobotomist documentary because it's widely considered to be one of the most controversial and unethical treatments in the history of medicine. It was a poorly understood methodology carried out in an unethical and unprofessional manner by modern medical standards. The Lobotomist documentary was a rather barbaric and disturbing portrayal of science at the time that you are sure to remember, and absolutely invokes an appreciation for the privilege that is modern medicine. Friedman was an over-ambitious scientist that practiced an unpublished procedure without medical license and left a great number of his patients disabled. Due to lack of Friedman's publishing and subsequent lack of peer reviewing, alongside Friedman's determination and positive media coverage, the lobotomy continued to be in practice for much longer than it should have. With the transition from lobotomy to antipsychotic drugs came increased research into the side effects, as well as increasing the transparency between patient and doctor. This means patients can have the choice of therapy with the knowledge of their respective side effects, leading to decreased compliance rates, with some patients believing the negative side effects outweigh the therapeutic value of the drug. Modern medicine approach to mental illness uses antipsychotic drugs alongside psychotherapies, such as cognitive behavioral therapy or talking therapies, to achieve the greatest therapeutic value while minimizing